webinar. Det TRS, Kompetansesenter for sjeldne diagnoser, som arrangerer dette webinaret. Og helt kort, TRS et nasjonalt kompetansesenter for 8 sjeldne og medfødte diagnosegrupper. Og vi en av 9 kompetansesentra under Nasjonalt kompetansesenter for sjeldne diagnoser. Vi også en del av forskningsavdelingen på Sunnaas sykehus. Vår oppgave å bygge opp og spre kunnskap om disse sjeldne diagnosegruppene, og vi driver forskning og utviklingsarbeid, og vi samarbeider da både nasjonalt og internasjonalt. Vi som arrangerer denne dagen i dag, vi representerer ryggmargsbråkteamet. Det vi erfarer både i møte med brukerne og personene det gjelder, og når vi reiser ut og i det vi leser, det at barna møter utfordringer på mange områder. Og 2 av dem det som handler om selvstendighet og overvekt. Og i den anledningen så har vi vært så heldige å komme i kontakt med psykolog, PhD, Amy McPherson fra Bloorview Research Institute, Toronto i Canada. Og vi har da gleden av å presentere henne. Hun forsker på barn med funksjonshemning og medlem av ekspertutvalget i International Federation for Spina Bifida and Hydrocephalus. Hun har en lang publikasjonsliste. Okay, and with this, I will switch to English, because Amy will of course talk in English. And Amy, it's a great pleasure to wish you welcome here to Sunnaas Rehabilitation Hospital and TRS. And we are very much looking forward to your presentation. Okay. Okay. You have your pointer.
Thank you, Maria. Thank you for inviting me. I'm incredibly honored to be here and seeing your wonderful center and meeting like-minded people here as well. So I'm very much looking forward to the next 2 days to meet with you all and to talk about your experiences and how they might be similar or different to where I work, which is in... So I've come from Holland Bloorview Kids Rehabilitation Hospital, a bit of a mouthful. In Toronto, in Canada. Has anyone been to Canada, Toronto? Yeah. Hopefully when it was warm and not in the middle of winter. It's not the most hospitable place in winter. So Toronto is obviously one of the bigger cities in Canada. And we have this beautiful building that we work in. It's been open about 10 years. And it's one of Canada's largest pediatric rehabilitation hospitals. And we're linked with the University of Toronto as well. So we have lots of trainees and students that come through our doors, as well as in the research department, we have lots of masters and PhD students that we help train as well. So we serve 7,000 children each year. We have about 600 inpatients on 3 units. And those units are acquired brain injury units, so either from accidents or stroke, tumours, and so on. We have an orthopedic unit, so a lot of kids with cerebral palsy, CP, that come to us after they've had surgery on their limbs, come to us for rehabilitation. And then we have a complex continuing care unit, which is kids who are dependent on 24-hour care. So a lot of ventilator dependence kids, quite severe. So we have those 3 units, but primarily what we do is outpatient work. And I've got these stats from our website, 58,000 outpatient visits in a year. So it's enough to make you feel tired. So tomorrow I'm going to talk a little bit more about sort of the research infrastructure of where we work. But today I'm going to talk to you about two topics, so self-management and obesity, which are very interrelated. But just so I have a sense of who's in the room, who do we have? Is it mostly clinicians, so physicians? Yeah. Oh, okay, I know who to pick on there then. Occupational therapists, as well, physical therapists, nurses, anyone I've missed? Psychologists, of course, I should remember that. Hello, but the psychologists in the room. And yeah, okay. Sorry? Dietitians, very relevant, yes. Okay. Perfect. So I have like my favorite people in the room, basically. Okay, this is going to be good. Okay. And so Maria and some of the colleagues have told me a little bit about who you see here, your clients. We see very similar. So we have spina bifida, muscular dystrophy, cerebral palsy, acquired brain injury, as I said. We do have a few others, but those are our most sort of common ones. We don't seem to have so many of the rare conditions that you have here. I admit I had to look some of them up and Google them and find out what they were. But we do; those are mostly who we see. And we do have a large autism program. We don't offer treatment, but we do diagnosis so that they can access other services. And we have a lot of research as well going on around autism as well. So that's who I am and where I've come from. I'm a health psychologist by background, and this will become very clear in the way that I talk about self-management, wellness, and so on. Any questions before I start? Okay, good. Hopefully there'll be questions afterwards. Oh, hang on, my pointer's not working, hang on. Okay, so I mean everyone's going to be very familiar with self-management, but this is how I view self-management. Helping kids feel in control, feeling empowered, and really taking control of their health and wellness. And so you can see that's very much kind of from a health promotion lens. And just sort of taking that health promotion, the definition I like to use is so in the process of enabling people to increase control over and to improve their health. And it moves beyond a focus on individual behavior towards a wide range of social and environmental interventions. So very much plan to talk about not this very specific kind of health behaviors people must and should do, but kind of looking at some of the things that influence that and how we can work with children and families to try and promote this kind of idea of control and health promotion. Is it working now? Yes. So I do like it. You'll notice I like my images. So what we're actually going to talk about today is a few things. So self-management, yes, but we're going to look at the things that contribute to overall self-management, health and wellness. And so self-management is a vehicle towards that. I'm going to talk about disability generally, and then also focus some on spina bifida as well, as I know there are quite a few people from the spina bifida team here. So that's why the words I've used here are things like self-management, but also wellness, planning, strong, coaching, goals, control, confidence. So for me, these are all things that contribute to a person's wellness and sort of optimal self-management. So self-management is this is how I sort of get the definition, or a definition that spoke to me anyway. So the individual's ability to manage the symptoms, treatment, physical and psychosocial consequences, as well as lifestyle changes, because we know, especially in acquired conditions, that can be a significant change in people's lifestyles. And then to self-manage effectively, it has to be the ability to monitor one's own conditions and then decide what the best appropriate response is. So either behavioral or emotional coping, and with the ultimate aim of kind of quality of life. So this is actually taken from the adult literature, but I think it's really applicable to the children and young people and families that certainly we see in our rehabilitation centre. Does this resonate for people? Is this something that's quite familiar, and the philosophy here, or no? Getting some nods anyway. Okay. I'll try and convince you by the end. Okay. So the first thing is, why is it so important? So I did my PhD originally in asthma self-management. So writing this talk was actually a nice kind of trip into the past, as well as it being extremely relevant for what I do now. I mean, the reason it's important, obviously, that advances in pediatric medicine means that many, many children are living, surviving and living even longer than they used to. Many treatments have improved. We've had lots more medications. So we were talking about muscular dystrophy over lunch, and how now they're living into their 30s sometimes, when before they wouldn't make it past their teens, which is fantastic, but it's also brought some other issues that need to be managed as well. So, and also many treatments have moved out of a hospital setting. You used to have to come to hospital for everything. Now there are many things that people can do at home that are part of self-management to keep themselves well. So the crux is that you're asking young people and their families to do all of these different actions. You know, it's often a very multi-component treatment regimes that need doing. So it might be dietary prescriptions, it could be laboratory work, lifestyle medications, coming to clinic. So we were asking our young people a lot, and they can often be complex, intrusive, painful, time-consuming, and put a substantial burden on children and families. And then we're asking them to do that at the same time of them growing up and being kids, especially around the time of transition. And I know that's an issue of interest to a lot of you. But kids are trying to go to school and have friendships and figure out who they are at the same time as managing all this. So it's a complex sort of dance, I think, with our young people about how we have our medical agenda or dietary agenda or whatever, then we're also asking them to do a lot as well. So that's the kind of the issue. And then you often read that when people don't adhere to our guidelines or our suggestions, we call it non-adherence, and we talk about how, we often can't understand why kids aren't doing what we ask them to do, because they'll feel better, they'll have better health outcomes, they'll have lower health costs. So there's a number of reasons. But I did put non-adherence in quotation marks, because I'm going to talk today a bit about how it's not about them just not doing what we're telling them. It's about working collaboratively with the families to figure out how can we help them feel most well. And that's not necessarily just that their lung function is over a certain level or their bloods get to a certain level or whatever. So that's some of what I'm going to talk about today, because in the real world, unfortunately, things aren't as nice and straightforward as we may perhaps want them to be. And I think as healthcare practitioners, it can be quite frustrating when you're saying, what if they could only do X, Y, and Z? Then they'd feel so much better, and then, they would use their drugs less or whatever. And I think sometimes we get frustrated and sort of feel like we're banging our head against a brick wall. And so hopefully today we can sort of think about some things that might affect that. And the reason why self-management then is so difficult is it often feels like this, I think, to children and families. They're trying to juggle 100 things at once. So I say not only life, getting to school, getting to work, getting people fed, making sure they do their homework, as well as trying to do a sort of monitor their whatever condition they have, but monitor, think about how to respond, doing all their assessments. So it's a big juggling act for them. And so that's why here at rehabilitation centres, we're the team that helps the young people kind of figure out what they should be doing. But then they've got to take that back into the real world and make that work in their lives. So there's a balance then between kind of the team and managing the health the rest of the time. And that's why it's so hard. And that's why so much has been written on it. I think we still are trying to kind of get to grips with exactly what this might look like for our children and families, and how it might differ between families. So as healthcare professionals and researchers, we need to build up children and their families' kind of confidence in managing their disability or their condition, whatever form that might be. So they can feel they can exert some control over their life and optimize their wellness. And we'll talk about that in a bit more detail in a minute. But I'm going to start with sort of classic self-management to begin with. And as I was looking around for sort of papers and research, what popped up but pediatric self-management, a framework. And it's always good when you get that paper where you think, great. Has anyone come across this? It was 2012. I don't know if anyone's seen it. So I was just interested in it because it looked at the different kind of components of self-management. And when I read it through, I thought it really kind of spoke to me, some of the things that it talks about in it. And you can see it's got these kind of concentric circles. Psychologists in the room, you've probably heard of Bronfenbrenner's ecological systems theory, way back in the hazes of school. And it's basically it's a similar idea, but it's the idea that the influences on health and health behaviours and self-management behaviours is multi-component, and it kind of has different layers of influence. So I was just going to sort of walk us through this a little bit. So as you can see, let me see if this, yes. So you can see it has 4 domains. So we've got the individual domain, family domain, healthcare system, and community. And that's where it's really quite similar to the Bronfenbrenner model. And so it looks at like how those different domains influence someone's desirable behaviours. So, you could, oh, hang on. Oh, now it starts working. There we go. So we've got our self-management behaviours in the middle. And that could be things like taking medication or monitoring symptoms, attending support groups, healthcare professional training. So when I'm trying to use an example from each of the 4 areas when we talk about this. So you can see it might be like the family's monitoring of the symptoms, but the individual taking medications and so on. So those are the kind of things that we want people to be doing. And those are all the things that keep the child physically well as well. So that's the kind of thing that we're aiming at. But then they talk about these processes. And processes might be things like communication with the medical team, stress management, experiencing stigma, healthcare decision making. So these are the processes that actually affect sort of the inner ring of these self-management. So if your communication between the team and the parent or the family is poor, if the family are not managing stress very well, if they can't go out in public because they're experiencing a lot of stigma, or kind of exclusion from the community, or even if the healthcare sort of process and decision making is not optimal, then all of those things will have a direct effect on them. And then we have our modifiable influences. So these are kind of traditionally things about knowledge, coping, peer support, clinic visit. So these are the things that we can do something about. In theory, of course. But we can teach families to have more knowledge about the condition. And our psychologists doing an amazing job about working with families around coping strategies, things like that. It could be sort of some peer support groups that we could set up to give some support to our young people. Or it could be, coming in every 6 months isn't working. Let's get you in every 3 months, and so we can have that contact. So these are the things that we can actually do something about in theory. But then we have to understand about our non-modifiable factors as well. And these are sort of traditionally some of your social determinants of health. So age, we can't do anything about that. So often socioeconomic status or where the person lives. As well as the healthcare access, and that might be kind of the terms of the healthcare insurance or the whichever country you're in, you know, the kind of the way they have their healthcare service set up, which is really sort of a lot of non-modifiable things. So when we look at it like that and think, well, why aren't they doing X? And suddenly we see this within this, you know, much broader context of things that affect them. And so things like in the individual domain, again, is a kind of where self-management responsibilities outweigh a youth's intellectual capacity or maturity. So the thing that always comes to me around is spina bifida and the executive functioning. I know we've talked a bit about that already before today. So those are things that we're kind of working with, and things like family structure as well, lone parenting, family communication, you know, who has responsibility for the different regime, you know, in the person's self-management activities. And then if we look at our community domain, you know, if individual and families live and manage within the broader community. So things like we're looking at school knowledge, school policies. Often schools have slightly strange policies that can have around sort of access and toilets, and schools may be inaccessible and so on. So we're really kind of relying as healthcare professionals for schools to work with us as well. I know probably social work probably did a lot of your work in schools and trying to kind of break down some of those barriers. And it could be around peers as well. So peer support programs can facilitate social management, self-management, and especially with rare conditions, and with the wonderful advent of the internet that is ever more available, and people can connect across countries. Certainly in Canada, because it's such a huge country, you know, we do have a lot of online things. So someone in British Columbia can talk to someone in Toronto who happen to have the same condition, where they might not have someone in their immediate location. And then in healthcare system, we have to be aware about the lack of culturally relevant treatments. And the interesting thing when we're thinking about research is we often have a lack of kind of ethnically diverse participants in our research projects as well. So we need to be mindful that the evidence that we're generating is actually not applicable often to everybody that we would want it to be. So we need to be mindful of that. I mean, the key thing really is the communication between families and healthcare professionals, and especially around kind of difficult topics like prognosis, or it could be around sort of difficult topics such as incontinence or weight management, obesity. And I'm going to talk about that in the next talk around how we might start that communication. But the key thing, I think, we're pulling this sort of model together, is that family-centered care is the critical piece. And it's about managing collaboration, expectations, that shared decision-making, not kind of making this decision and expecting the family to follow blindly, but sort of working with them to figure out some of these pieces that we can see as sort of the complex nature of everyday life. So I'm interested to hear from you. Does that model make sense to what you see in your daily practice? Or am I, yes? Okay. So you're not sitting there thinking, what is she talking about? Okay, well, that's good. What sort of barriers or what are things that might help the young people you see with their self-management? Well, okay, I'll ask you an easier question. What are the things that make self-management difficult? I have a long list, so I'm going to see how many of these you get. So cognitive issues for sure, yeah. Following instructions, juggling multiple things at once, certainly around executive functioning, planning, goals, yeah. Okay, I'll tell you my list and you can agree or disagree. How about that? So things like self-efficacy, so confidence, and can it be quite specific confidence to that what you will do will have an effect and have a positive outcome. So this was really key with us in our kids with asthma, which is, they had to do their peak flow, they had to, look at their chart and then figure out what they had to do next. And for some of them, they didn't think that they would be successful doing it. So a lot of what we were talking about is this control, right? Feelings of control over what they're doing and that they'll be successful. So we often see that with self-management and things like in spina bifida around toileting, bowel regimes, things like that. Something else I have around the therapeutic relationship or that communication. So build it, and Marie and I've talked at length. I've loved hearing Marie's stories around her general practice and then coming here in her philosophy around practicing. And really that very strong emphasis on the therapeutic relationship. Building that rapport. You can't kind of come in day one and then start issuing this long list of things you want them to start doing without having built that sort of trust and rapport. And that's certainly something we see in our rehabilitation centre a lot. And is one of the many nice sides of working in rehabilitation is you often build relationships over years. You're seeing the kids over many, many years and get to know them and their families and their dog and their auntie, whoever, who's having an operation. And, you have that ongoing kind of relationship often with families. Is that the same with here? Yeah? Okay. Also talking about kind of acceptance as well, acceptance of the condition. And that might be for the young person. It could be for the family. We know a lot of our families struggle, especially things like Duchenne muscular dystrophy, where they know this is going to be the person's going to have a shortened life, something that they were going through life quite well and quite nicely until this major crisis happened. So to be able to sort of accept that and then to move on to do something about it and look into sort of therapies or whatever, it can be a huge adjustment within the family, and all the roles of the family suddenly change. Then with the siblings, suddenly kind of becoming much less of a lot of attention being put on the one that's being diagnosed and so on. So from the child as well, acceptance, and we see that a lot with autism as well, autism spectrum disorders, that kind of acceptance, and how that might affect that young person's identity as well, seeing someone, as someone who is disabled or has a disability. And a lot of our kids don't view themselves that way, and that's perfectly fine, but it can sometimes need to be worked through in order for the sort of self-management to really fall into place. Anything I haven't mentioned? Lots, I'm sure, but okay. Okay, so so the other thing I have around it is developmental stage, which I've already talked about, and especially in those teen years. I don't know if anyone's got teenagers here, but that lovely phase when they don't want to do anything that you suggest, and they want to be independent and autonomous and be as far away from your parents as possible. And again, if you've got like a complex condition or that you need to manage, that can be extremely stressful for everyone involved. The parents having to give that independence and that sort of letting go and autonomy, and worrying sick about are they doing their X, Y, and Z that they need to be to stay well? Are they taking their medications? Are they monitoring their symptoms? So I'm just going to sort of talk a little bit about self-management and spina bifida, as I know it's an interest of many people here. Who works with spina bifida here? Okay. I'll tell the rest of you when you want to start joining in again. And there's been some quite interesting papers written around self-management and spina bifida because it's such a significant topic. And there's a couple of interesting papers, one recently by Sally Lindsay, who's actually a colleague of mine at Bloorview. And then, what's her first name? Kathy Sorin, is that right? She's from the United States. She's written a huge amount around spina bifida and self-management. I think she's retired now. And then Nicole Fisher was actually a medical student of mine who did a really interesting project around how incontinence impacted young people's social inclusion. So I'm just going to sort of touch on all three of these papers, looking at self-management through a sort of spina bifida lens. So we are quite preoccupied a lot of the time with the medical management of spina bifida, sort of trying to make sure that they are still go to school, that they have everything they need in school, and toileting is such a substantial issue in school, which we found through our study. Kids not wanting, they have a special toilet to use, or they can use the staff toilet because they can leave their supplies there. And that's the last thing the kids want. Oh, I'm going to go and use my special bathroom, really making them stand out. So there are kind of big significant impacts on lifestyle, around the bladder and bowel routines, and something that our families struggle with quite a lot. So the outlook of a lot of the kids in Sally Lindsay's and Kathy Soren's research talked about managing fatigue and pain and daily self-care, and that was what they were most preoccupied kind of with. But they had a bit of a lack of information about the complexities of spina bifida. Colleagues of mine talk about how, the only guaranteed thing about spina bifida is that there's nothing guaranteed. So that every single person is completely different. You never know when something's going to come out of the blue. It's a little bit unpredictable at times, especially around incontinence. What you do every day might suddenly one day not work. And so there's that lack of control, which can be quite problematic. So our young people, and the paper's written about adolescence, that key time, and so they talked about relying on parents for some of their care, but then feeling conflicted between needing that assistance and then wanting that independence as well. So there's sort of tension between, I don't want to do it all myself, but I know I don't want my mum and dad around as well. And we see that in the spina bifida clinic, sometimes people still doing their child's, say, like catheterization, and their kids are in their teens. And so how do you talk about kind of what's appropriate and what might not be appropriate as children kind of get older? Things about identifying goals and priorities, very, very important. But we talked about skill development often being quite delayed. So Sally Lindsay does a lot of research around employment, and how, kids with disabilities have vastly low, or people with disabilities have vastly lower levels of employment. And so often those skill developments could be sort of delayed, not only because maybe of the executive functioning and cognitive aspects, but also about the lack of opportunities to do a paper round or get a job in a supermarket, the things that a lot of us did, I think, when we were growing up, to kind of develop those employment skills. And even the kind of like the etiquette of the workplace, what do you wear and what's appropriate and what's not. And these things you kind of learn as you grow older, but kids with disabilities generally may not have that experience and those sort of opportunities to develop these skills. So those were quite significant in the youth with spina bifida. And then they also talked about peer and family relationships, and about sort of a range of coping mechanisms that they used to kind of protect themselves against kind of this distress or exclusion. And really kind of emphasizing something that I think we all know, is that relationships enhance a sense of belonging and well-being. And that stigma, social exclusion affected their self-esteem and their self-concept, so how they viewed themselves, their values and beliefs and what they stand for. They often negatively compared themselves to other people, which again often, in fact, impacted their quality of life. And so really kind of working with young people to advocate for themselves and to challenge that discrimination, and focusing on strengths, and trying to act normal. When we talked about this idea of not chasing normalcy. So how do we be normal like our friends? And again, I keep thinking of this one girl that we interviewed as part of our incontinence project. And she would, unfortunately, she had, within the class, people knew her to smell quite badly. And because she would sit in wet clothes a lot rather than go out, and when she'd have an accident, rather than go out and change. And so some of the adults were like, well, why don't you just go out and change and put clean clothes on? And she's like, but people will know I left the room in skinny jeans and I've come back in I don't know, something else. And so for her, it was better just to kind of ignore it, and because she wanted to be normal, and she didn't want to wear her orthosis, her like kind of splints on her, because she couldn't get her skinny jeans over the top, because that's what the kids are wearing, and things like that. So I think we forget the huge influence that has over what kids do and how they engage in sort of what we would call, self-management, because they don't want to draw attention to themselves. And unfortunately, the outcome was that she drew even more attention to herself. So it was really working with her to figure out what would work in her lifestyle and she would feel comfortable with. So self-advocating, and then the idea of disability identity as well, about whether to integrate a disability identity into yours. And again, it's not there's a right or wrong, but people do it in different ways. And sometimes when they don't, it can lead to other issues and other sort of tensions. And I'll be talking a bit about that tomorrow in our transitions talk tomorrow. So at Holland Bloorview, we have a residential life skills program every summer, and people can come. They live in downtown Toronto in a university residence, and they can stay up all night and feel absolutely horrid the next morning, but they have the opportunity to find out that you feel really horrid when you stay up all night. And it's sometimes for them the first time they've ever met other people with disabilities, because they come from quite rural places. And we see a lot of that about how they're like, oh, there are other people like me. Okay, interesting. And so how they start looking at themselves slightly differently. So I'm going to sort of move on to wellness, because I think this is my big pitch to you all. I think this is what we should be focusing more on, although self-management is, of course, a part of this. And there are lots of definitions, but I love this one about individuals living to their fullest potential, because I think it really encapsulates what we try and do for the kids with disabilities and conditions that we see. It's not about making them the best at X, Y, and Z. It's saying, trying to find out from them what they want to be and helping them be the best they can in that way, whatever that looks like for them. And it will be very different between people. So we've also looked at how so many other factors affect self-management and health and wellness rather than just the medical management. So it's a much more holistic kind of approach. And I use the World Health Organization quote about saying health is not just an absence of disease. And I think that really speaks to this idea of wellness. And it takes a very positive approach. I think a lot of the time we think about what kids can't do. And we often ask parents what they can. So can your child do this? No. Can you do this? No. And we don't often always go straight to the positive. What can they do? What are they really good at? What do they really enjoy doing? And I think sometimes certainly I have to remind myself to go that positive approach. Because parents tell us, I've just spent all day telling you what my child can't do. So thinking a little more holistically. And wellness is often considered to the end point of many different interventions. And it's a very dynamic approach, very strengths-based, rather than the sort of traditional deficit model of disability. And I really think this is a paradigm shift in rehabilitation. And I think it's really needed, and I think we're on the way. But I also think we need to know a lot more about how we can work within this wellness model. And the key thing is, it doesn't mean that the medical intervention care isn't needed. I'm not saying that at all, but it's one aspect of it. It's holistic. It's about informed choices. It's about being collaborative. It's about tailoring it to the individual. And that's the thing is, that we all know there's not one thing that works for absolutely everyone. And it very much links in with the ICF-CY, so the International Classification of Functioning Disability and so on, the really long one, yeah. So it kind of links in really nicely with that as well, about this is not just about function, range of motion, although that is important, but there's the kind of the participation piece, the inclusion piece. And I was talking about this talk with a colleague of mine, and she's like, oh, I've got a really good example for you, so I'm going to steal her example. And she talked about in the spina bifida clinic, they were working with a young girl to use her stander more. So, sort of a frame that she had to stand in it so many minutes a day. And the therapist said, oh, you should do it in front of the TV and while you're doing your homework. She's like, then you'll be able to get it, do it really easily. It'll fit into your life. And it seemed like a really good idea. I felt very pleased with herself. But what they hadn't looked at was the young person couldn't, where the TV was, she couldn't see it from where she was on her stander. And the stander didn't fit up at the table where she did her homework. So she didn't do it. So that's not non-adherence, but because it wasn't sort of built into actually her real world. And in the end, the family said, you know what are we getting out of this? And they chose as a family not to pursue that kind of part of her rehabilitation. So it's kind of an interesting thing when we're talking to people to figure out that very much like client-centered approach. And I'm sure you do that here all the time. So, what's interesting is that we often don't see wellness and disability as working together. And so disability doesn't preclude wellness, and some have said that it actually highlights it further. And there are two really interesting papers about wellness and disability, Putnam and Breen, and they're for adults, but I think we can learn a lot from them. And so they did some interview studies, and one of them was saying, well, although I'm in a wheelchair now, actually health and wellness means more to me now, because it's about as much as I can do to be well. And this was in an acquired condition. So they said wellness actually took on a much stronger sort of influence in their life once they were experiencing a disability. And then as I was saying, this sort of collaboration, negotiation is actually the critical piece. Okay, what works for you as a family? What are you bringing? What am I bringing as a healthcare professional? Okay, let's collaborate and negotiate and see what works for all of us. And I love this quote. It says, it helps if you've got a good doctor. And I define that as someone who will listen to you, who will work with you, as well as your disease. So that kind of like two-way, it's not just about them sort of saying what they need. And as I said, it links with the ICF-CY around activities, participation, environment, all these things that we see effects. And again, this quote was like, health and wellness is a total package of feeling positive about ourselves, having accessibility to be able to go out and do things. So living in the world, having that social inclusion is really seen as so critical to health and wellness. And I just think this sums it up, that it's as though I often see the medical profession and society in general as either you're well or you're sick. And these sort of two, they like dichotomous kind of approaches. So you're either disabled or not disabled, and they describe it as one of the biggest fallacies that the medical profession has ever kind of taken on. And I think, again, we are working our way away from that kind of model, but again, a good reminder. And Marie was just saying she had read this paper, which is always very nice when someone's read your paper. And this was a few years ago when I sort of first joined Holland Bloorview, and I was really intrigued about so what do kids with disabilities think healthy living is? Do they see themselves as being healthy, having health, wellness? And it was interesting. So we did a series of focus groups. And we have a Busy Bodies program, which is kind of a health promotion program. It does sort of healthy snacks, healthy eating. They can try out a load of new activities they might not have tried. They get yoga. They do yoga, which some years has been a great hit. Some years people have hated it, but try it out. They have a lot of adapted equipment that people can borrow. So it was an interesting one. So before they started this, we did focus groups with them to figure out what do they think is healthy and so on. And they all thought that being healthy was important, and as someone with a disability, that was appropriate. And they said, oh, I know I have to do this and I have to do that. And when we actually said, so for example, food, and we said, but do you do that in real life? Oh, no. So as with many of us, there's a gap between the knowledge and then actually implementing it in their daily life. And I think that is the same for all of us. But these young people might need extra help from us to figure out how they integrate that into life and how it looks for them. For example, they love their sedentary behaviours. Again, probably not hugely surprising for children aged 7 to 14. They all like their video games and everything. But we know kids with disabilities have high levels of sedentary behaviour. And so again, it might be healthcare professionals can have a role in helping them engage in identifying activities that fit within their abilities and their strengths. So that was kind of an interesting one, and hearing from the kids themselves, as always, was hilarious. And we got them to draw pictures as they were speaking, and some of those are quite funny. I have to put them up on my website. But interesting to hear their perspectives, because that's ultimately who's going to be doing what we want them to. So if we're thinking about wellness approaches, what is a wellness approach? What do we do to try and promote wellness? So there are things like family-centered practice. So that thing, working with the family collaboratively, negotiating what works for them. Some have suggested community-based services, so not always coming into the hospital, but I think with rehabilitation centres like that, like this, and with Broadview, people come in, they're very familiar with it. Self-management is a wellness approach, as well as that empowerment. So our guy at the beginning with his superhero costume on, empowering kids. And what Breen argues is that this leads to improved health behaviours, better psychosocial functioning, reduced hospitalizations, and increased client satisfaction. And it's actually a very interesting paper. He's got the evidence and references for all of those points about when and where those have kind of improved as a result. So I was being very optimistic and was hoping you could tell me what sort of strategies you use to promote wellness. Is wellness a concept that you use in your daily practice? Is this a new concept? Okay. Yes. 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 So quality of life, very similar, very kind of in line with that. And there are many quality of life assessment tools and things like that people often use. So what we have started to do at Holland Broadview is coaching, health and wellness coaching. And we're hoping to get sort of the majority of the hospital workers trained in sort of this more coaching approach, which is more collaborative and working with the young person. And an example of health and wellness coaching is this goal, plan, do, check. I don't know if people use that. Apparently it's my coaching colleague said, oh, yes, it's about kind of working with the young person to identify a goal that's meaningful for them, that they want to work on. They use like real world situations to promote positive long-term behavior change through that goals. And then the coach would work with the young person and say, okay, so how are you going to do that? What are these strategies you're going to actually use to be able to work towards your goal? Then the young person will go off and try it. And then they'll come back and say, oh, so how did that work? Like, what went well, what didn't go so well? So an example, a lot of our youth want to use our public transit system because it gives them, again, more independence. So whether it's getting to school on their own, and we're talking sort of in the teens, and our coaches work with them quite closely around, okay, so you're going to take the bus from here to here. That's your goal, to get from home to school. Okay, so so they might spend some time with the maps and the timetables and figuring them out, and then they might do a plan and try that. The coach will go with them, and you offer varying levels of support. And then afterwards, okay, so what went well? Okay, so you went entirely the wrong direction. How could you make sure that doesn't happen again, and things like that? So really working with the young person to kind of work out where their strengths are and what they did. And actually coaching studies in children with physical disabilities shows a lot of promise. And also, importantly, kind of sustained behavior change, because that's what we want. Is short-term behavior change often isn't much. It's good, but it's not really what we would ideally want. We want them to sustain that. And so we've seen improvement in goals related to self-care, productivity, leisure, and mobility. So there are studies out there that look like that. I just realised I've got 45 minutes and not an hour, haven't I? So I will wrap up. I was settling in for the full hour then, I realised. But I just wanted to kind of flag this, that one form of coaching is solution-focused coaching. And that's where it's very much led by the young person around getting meaningful goals. It's client-driven. It's very much strengths-based. So it's not about problem solving. They don't do problem solving there. It's about solutions and being very focused. What went well? Tailoring it to the individual. I did have a video which I won't show you. But it's basically, it's meant to be brief. It's not meant to be long-term, sort of, months or years. It might be 6 sessions. And the central part of it, if it works, then don't do anything about it. If it worked once, then do it again. And if it didn't work, then don't do it again and try something different, is the kind of crux of it. And it did come out of solution-focused therapy, from the therapeutic world, sort of psychotherapy. And it's shown some very good outcomes. And these are just some, and I can send you my slides if people want to get the detail. But it's sort of, rather than the healthcare professional being the expert, it's very much client-driven, traditional focus on deficits, no focus on strengths. So we can see it is quite the paradigm shift. It is underpinned by self-determination theory, which is about making people feel autonomous, making them feel that they are competent, and then also making people feel that they're sort of supported and have the relationships to actually support their behaviour change. So I think it's we don't know a lot about solution-focused coaching right now. I mean, the research is growing, but I think it's a really exciting approach. And I know you've used goal management theory, and this uses goals as well, but it's a very interesting theoretically kind of sort of supported approach to working with clients to achieve their wellness outcomes. And we very much use goal setting, which means we can compare people. So even though you might be coaching 10 people and they might have 10 completely different goals, by using standardized goal setting, we can actually then compare them and see whether interventions work on a number of different people. So rather than sort of having an N of 1, by using things like the COPM. Does anyone use the COPM here? Okay, great. Or then gas goaling as well. Yeah, they often go together. Yeah. So we use that a lot to evaluate coaching as well, which is a really nice way of sort of comparing across quite different people. That was a study I did. It was great. So I'm happy to talk about it. It's under review right now. If it comes out, I can send it. But we used solution-focused coaching with kids with Duchenne muscular dystrophy around wellness goals, and just as a feasibility study, and it worked quite nicely. I submitted it to a publication, to a journal, and the reviewer said, he said it was callous of us to talk about, because it's part of, you talk about their future, so their preferred future, where do you want to get to? And he said it was callous of us to talk about future with children who had a progressive condition. So I wrote a stinking letter to the editor. But I think that those attitudes are still out there, that, even they're going to die in their 30s, or we better not do anything with them. So I think that is still out there, and we need to be advocates for the fact that, they certainly do have futures and certainly do have lives that might look different or be shorter. So, and I think wellness fits in very nicely with its strengths-based approach. So just to conclude, so self-management is very important, but I think addressing overall wellness is probably a more, I hesitate towards effective because we don't have the trials, but it could be a more sort of feasible and a more profitable approach. Strengths-based approaches can help, I should say, enhance motivation to engage in health behaviours, and it's inherently child and family-centred care. And solution-focused coaching is a tool that does sort of certainly align with all of these things as well. So I wish I had come up with this saying. I hadn't. I've stolen it. But I think that sums up really where we're coming from and where the contemporary approach is to self-management. So I apologise for going over my time. I was thinking it was an hour, but I'm happy to take questions either now or afterwards if people want to come and talk. So thank you.
Thank you, Amy. Vi har egentlig nå en 5 minutters pause bare, før Amy skal ha sitt neste foredrag. Så jeg tenker, hvis dere har noen spørsmål knyttet til dette foredraget, så kan man ta det etterpå. For da skal hun holde på fra 2 til 3, og så kan man åpne for spørsmål fra 3 til halv 4. Så jeg tror kanskje vi tar de 5 minuttene som vi har nå, og så starter hun igjen om 5 minutter. I just said. Jeg glemte å informere om at det er forfriskninger her nede. Hvis dere vil ha litt frukt og litt å drikke, så er det her nede. Da nærmer klokken seg 2, og vi ber om at alle kommer inn i salen igjen. Kjære dere, da åpner vi for Hallo? Det var bra, da ble det stille. Da åpner vi for neste avdeling, hvor Amy skal snakke om obesity. Okay, Amy? Please.
Okay. Well, thanks for coming back. That's always a good sign. Okay. So, I mean, obesity is not a very far step from self-management and wellness. And it certainly encompasses a lot of the topics we'll talk about, but we'll be a little more specific in this next sort of, and I do have an hour now, so I will keep it to the right time. And Marie has told me that, you know, this is an issue that affects many of your clients. Is that correct? Yes. I will also try to speak more slowly. I get excited. That's the problem. So just to kind of frame the issue, I pulled some stats, and these statistics are actually quite old now. They're over 10 years old. But you can see, so the blue is disability, the green is no disability. And if we look at those who have overweight or obesity, we can see the blue is much higher in all of the different categories. The statistics say that children with disabilities are 2 to 3 times more likely to have obesity than our typically developing youth. So in Canada, about 30% of children have overweight or obesity. I'm not sure what it is in Norway. Do you know?
I don't think we know, but we know. I don't think we know exactly, but in general, there is obesity up to about 28% in the population in general.
So that's adults and children. Yeah, so similar. Yes, yeah.
It's about 18% in the children's population.
Okay.
It has stopped and it's not increasing for the last year.
So 18% in the children's population, but it has sort of plateaued. And I think many countries have shown that, and there is a little bit of some researchers will still say, and it's increasing in everyone, and other people are saying, well, it's tailoring off. So I think some of our interventions are starting to have an effect, but the levels do still say it's higher than we would want it. And certainly in disability, they're much higher. And just a note about, and we're going to talk about language today. So now people are saying we say someone with obesity rather than someone who is obese. So I will try and use that language. I'm still getting used to it, so apologies if I slip. But really trying to use that person first language like we do with disabilities now, someone with a disability, someone with obesity. So, and then from a different data actually, this shows about the sort of much higher percentage. And this is only obesity. This isn't overweight as well. So, which is why it's only just over 20%. So again, quite sobering statistics. So I thought I'd kind of just run through some of the main sort of what we see, and then some of the main risk factors for disability. But certainly this is a problem because we see that children with disability generally eat less fresh produce, more high fat and fast food, and more chocolate. They're more likely to engage in sedentary activities and have lower participation rates in physical activities. These were actually collected by colleagues in Canada, and you can see they're quite old now, the references, but I don't think much has changed, certainly from not what we see generally. Is this a pattern that you see here? Just a yes or no? Yes, yeah, okay. And so the reason why this is a problem, and I show this in every single talk I ever do, is because our children with disabilities are at increased risk of developing obesity, which then often results in secondary conditions. So it might be pain, more pain than usual. It might be sort of more problems with mobilization than they would have generally with their condition. Skin breakdown, especially with spina bifida, I mean, terrible problem as it is. Obesity can make that worse, which then disables the child further, which makes them put then at greater risk of obesity. And round we go again in the cycle. So we can see a lot, our kids with disabilities that can be quite excluded anyway. And we know children who have obesity are also excluded. So, again, we're really enhancing the risk of social isolation for kids with disabilities and obesity at the same time. So, what are some of the reasons? And when I say what I work on to people, they're like, oh, well, it's just because they can't run around so much. And certainly that is one issue, but there are many more, and many I discovered along the way that I had no idea about. You may do, but I'm just going to go through quite quickly. So yes, mobility impairment certainly, can be an issue of not expending as much energy. But that's for a number of reasons. There could be complications such as pain or incontinence that put people off doing physical activity, even if they're physically capable of it. Certainly we know our kids with incontinence, they don't want to go out and start jumping around and running around and risk an accident, so it can be very off-putting. Again, they might have problems with balance or coordination, and it's hard, I think, as kids when they do team sports, they don't get picked for the sides because they might run slower or have poor balance and just not have those what do they call it, physical activity literacy. So the catching the ball, the running around, those things that a lot of other kids develop early in life. So that's sort of so far okay, what you would think. But then there's the physiological risk factors. And so, there are certain conditions, obviously, like Prader-Willi syndrome. Do you see Prader-Willi syndrome here? Yes, yeah. So, that's a very big part of that condition, as around this sort of predisposition to eating. But there's other medications as well. We were talking about Duchenne muscular dystrophy at lunchtime. And, steroids have made a huge difference in the lifespans of these boys. But also, unfortunately, one of the risk factors, or one of the side effects, is substantial weight gain. So, while we're making improvements, we're also creating some of these difficulties. So that can be a risk factor. And then something that I was very surprised when I started working with spina bifida is around the Chiari-2 malformation. So the slight brain structure, slight difference, which can affect swallowing and gagging and breathing. Again, not very useful for when you want to go and be physically active. And then also affecting food and the textures that people want to eat as well. You probably see that clinically, how, our kids love white bread, chicken nuggets, chicken fingers, fries, anything involving white. They like potatoes, but anything with any fibre or goodness in whatsoever, not so much. And yes, that's a child thing to a certain extent, but certainly with that Kyrie too, it can really affect the tastes and textures that they find bearable. So it was a lot of energy-dense food. And then metabolic irregularities as well. So, kids are having slightly different metabolic systems, and our dietitians really struggle when parents say, well, how much should I be giving my child? And they're like, we don't know. We actually don't know. In spina bifida or other conditions where they might have different muscle mass, less lean tissue, and so on, about kind of exactly how many calories a day. And so parents find that very difficult. You're saying my child's overweight, but you can't tell me what to do about it. So the physiological side is a much bigger side than I realized when I first went into this. Obviously, then you've got the environmental risk factors, so lack of special facilities and equipment, and not just sort of accessible equipment, but having staff who are trained and who are confident in working with people with disabilities. Many trainers and gyms will not touch someone with a disability. They don't feel they have the right skills, they're worried about liability. So it can be quite difficult for our kids to find places where they can work out safely with the, and also with attendant care. So can someone take them to the toilet if they need it and things like that. So big barriers around there. And in Canada, certainly, families where there is a child with a disability have significantly lower income. So already have some challenges there with the sort of socioeconomic status, and then being able to find the money for all the different programs and adapted activities can be difficult. So other things that affects. And then obviously where sort of I come from is around the psychosocial aspects and around the low self-efficacy that I talked about earlier. This lack of feeling of control over your life can be quite difficult. And I am not going to bash parents. Parents have extremely hard jobs. They often have, they're often exhausted outside of therapy and taking kids and trying to get the house running and eating. Many people don't have the energy or time to come home and make sure that there's a plate with 4 colors on it. And, a lot of people use convenience foods for a very good reason. There may be a lack of understanding about the child and what the child should be having and doing. And we know a lot of parents underestimate what children can do physically and physical activities, so they might restrict them. We see this in the hospital all the time. So we have a coffee shop that sells donuts. And we see all the time people coming out of their appointments. The kid, child's hungry. They've been there a long time. They're bored. They might be in pain. And as a parent, I think you want to nurture your child and often use food to pacify the child or to make up for being excluded, not being invited for things, having painful conditions. Sometimes the only thing you can do as a parent is feed your child. You might not have control over anything else. So it's certainly not blaming parents at all, but it's something to be aware of when we're working with them around this issue. Often people use food as rewards as well. I think anyone who's a parent here, I'm sure, has used food at some point. Is anyone going to say no? No. I use food to reward my cat, so I'm sure we do with our children, and it's a very normal part of parenting, but it takes on extra qualities in kids with disabilities. And then differing priorities. It's just sometimes, getting through life with everybody living is the priority for our families, and may not have extra time to do that. So we need to really take that into account. Is coming back to this wellness, working with the families, what's important for them, what can they do, what do they feel able to do. So a really good example is spina bifida, and this is sort of one of the reasons why I've done quite a bit of research in this area. They have the mobility restrictions, the altered eating practices because of the Kyrie 2, the tastes and textures. Also, we see children eat or drink food to manage their bowel and bladder. So they might not drink all day at school because they don't want to use the washroom, or they might avoid certain foods if they know that's going to make them need to go to the toilet. So again, working with the child to figure out, well, why aren't you eating this and that? Or why are you only eating bland white foods, you know, to get a sense of where they're coming from. Concerns about continence, the metabolic neuroendocrine disturbances that they have with the altered muscle mass. Cognitive impairments, which again, I know the spina bifida team here have a huge focus on, that executive functioning, the ability to plan, the ability to carry on and carry out things can be difficult. And so the result in the literature is that they have very high level of sedentary behaviours, much lower fitness, higher levels of obesity, and obviously that then increases their risk of cardiovascular disease going into adulthood as well, and many other things, type 2 diabetes and so on. So it's unfortunately a good example of how all these things come together, these risk factors around disability. So my research tends to fall into 3 groups. How do we even know if someone has obesity? How do we talk about it? And then what do we do about it? I think I'm going to skip through a lot of the assessment because I'm not sure how relevant is assessment to people here, like how we actually measure, and is it something people do a lot? Very, okay. You're just encouraging me now. You've got another 2-3 hours, right? Yeah, okay. So I will go through, but basically, why is growth monitoring important? You know, anyone who's had any child knows the second they step over the doctor's threshold, they're weighed and measured and written down. And we have something called the Red Book in Canada that all new parents are given, have all their things in there. And so with kids with disabilities, still the same, but growth is important to either confirm they're growing appropriately, as you would expect, or hopefully, or to identify a nutritional health concern as early as possible. So all the evidence and all the recommendations are saying, you know, obesity prevention is the key, not letting them get to that point and then having to manage it. We all know, I think many of us in this room have been on a diet at some point and know how hard it is to lose weight. So early detection is the key thing that many of the statements around World Health Organization and so on have said. So I'm just going to go on and say about assessment is problematic for many reasons. I mean, what we're trying to find in terms of obesity is this excess adipose tissue, but unfortunately, there isn't a gold standard. There isn't a measure that works really well for kids with disabilities. So BMI, body mass index, is used. Do people who here uses BMI? Ish, yeah. Because we don't have anything better, probably. And it's been criticised because often our kids with disabilities have differing body compositions, especially in spine. Again, I keep going back to spina bifida as an example, but it is relevant for others. But at the moment, we don't have good alternatives, so we're sort of struggling to know what to do. And so BMI is still being used, and we did a medical record review in our hospital and found very low levels of people being weighed and measured. And I wanted to know, well, is this the same in all spina bifida clinics? So we did a survey across all of Canada. So we have 17 spina bifida clinics in Canada. I think we got responses from all of them to find out what they were doing. So they said, oh yes, we regularly weigh and measure all of our children. And I said, okay, this is them reporting it. So maybe they did, and we're a terrible hospital. They used many different assessment approaches. There was some awareness. People did say they knew it probably wasn't the best thing to use, but they didn't have anything else. Reasons why they said they didn't do it was about time, lack of equipment, and lack of expertise as well. And so one of the things I was interested in is that, okay, so you say you're weighing and measuring kids, but are you then talking to them about it? because there's not much use weighing and measuring someone if you don't communicate it. And many of them said, oh no. So you wonder what's happening with that information. But I mean, it really does show what a difficult issue that is, and we'll talk more about that. So we're basically looking at all the different ways. So there's many different ways of measuring height. Often with our kids, of course, they can't stand up straight to be measured at a standing scale. So proxies have been developed. So the ulna, also the wingspan, arm span. People use that here, the arm span or ulna. Okay. Yeah, there are problems with all of them, especially around accuracy. And so we got permission to go into the spina bifida clinic, and every kid that came through, we did their height, their ulna, their arm span, body fat, using skin fold thickness. We weighed them, and then we also did their waist circumference. And we wanted to look at many, many different things, but what I'm going to talk about today, I think is quite interesting. And we looked at, okay, BMI isn't great, but people are using it, so we should know what's going on. And we calculated BMI using their standing height, their arm span, and their ulna, because we know all of those are being used in various kind of combinations. When we use standing height, it highlighted about just over half the children fell into the overweight, weight, or obese category. When we used arm span, it told us about 40% of them did. And then when we used the ulna, only 25% of them were. So that's really interesting. Depending on what we're using, we could be massively under-detecting or over-detecting overweight or obesity. So clinically, this is kind of quite an issue to take into account. And then we also looked at waist circumference, body fat, and the waist to height ratio, which is people have used for children. And then, so 45% of them had excess body fat, which I think is a huge number. Here we can see waist to height ratio, about 70% of them were flagged. So again, massive number. And then, so the 90th percentile is what they recommend to stay under, but the 75th to 90th still does have some health risks associated with it. So we can see about 40%. So I think our conclusion is BMI has many, many limitations. Using height, standing height or lying length seems to detect obesity the most. It didn't detect overweight very well. But I think the take-home message is that it's a prompt to discuss the topic. It's not kind of saying there's not a number that they should be. It's more because it's all over the place. We need to say, okay, this is something that we need to investigate and explore, rather than saying you are overweight, you are obese. It's more like, okay, let's look at what you're doing. Are you happy with where you are at the moment? Do you have any concerns? How's your health? Are you being excluded? And looking again at those broader wellness factors, as well as the weight on top of that. So that was kind of an interesting topic. But what came through again was, we don't know how to talk about it with the families. And we know that weight communication can have a huge impact on families' willingness to engage with healthcare professionals in the future. So even with typically developing children, if they have a negative interaction with doctors early on, they are far less likely to engage in treatment for overweight and obesity later on. So it's really critical that we get this right. And many healthcare professionals feel very underconfident talking about it. It's a very difficult topic. It's a very value-laden topic. Obesity has a very negative connotation in today's society. It's not seen to be a good thing at all. People often label people who have overweight and obesity as lazy, or many, many negative connotations. And so as healthcare professionals, it's often a hard one to bring it up. What words do I use? Do I talk to the parents or the child or both? Do the child go out the room? Am I going to give them an eating disorder? You know, there are many different reasons why we often don't feel confident about it. So we thought we'd ask people. So we did a study that asked children with spina bifida, their parents, and healthcare professionals across Canada. So what's happened to you in the past when you've tried to talk about this topic? What are some of the ways it went well? Did you have any disasters? Tell us, you know, how you feel about this, how you approach this topic with your clients, for the healthcare professionals. And then with the children and families, you know, how do your healthcare professionals ever talk to you about healthy lifestyles, about diet and things like that? And how would you like them to talk to you about it? What sort of words do you want them to use, and so on? And also, what are some of the barriers to talking about this topic? And so we had, do the math, we had over 50 people we interviewed. The children were 6 to 18, and the majority of them had myelomeningocele, so this more serious form. We came up with 4 themes. So the first one was, you know, in many discussions we've got the healthcare provider, we've got the parent, and we've got the child, and there's this sort of triadic communication. And what they talked about, or what came out from the discussions, was that they all approached it differently. So everyone waited for everybody else to bring it up. So the healthcare, let's just say the nurse. It was all of them. The nurse would wait for the parent to bring it up. The parent was thinking, well, if they're worried, I'm sure the nurse would bring it up. And so everyone's waiting. And we have this kind of disconnected triad where, you know, parents feel that they should be responsible for it, but only if it's a problem, that the nurse will bring it up or the healthcare provider bring it up. And feeling frustrated when the healthcare professional says your child's weight is a problem, but then has no solutions. So that kind of really affected the sort of trust within those 3 people, and everyone wanted to talk about it differently. And the children were quite happy to talk about it. So when we asked them, they were like, oh yeah, I'd rather they just brought it up, which is often not what we anticipate, and we kind of are worried about doing that with kids. So that was quite interesting. And then our second sort of theme was called Doing No Harm. And again, this was very much around that therapeutic relationship. So the healthcare providers were very worried about ruining the relationships they had built up, you know, sometimes over years and years with these families, worried that they wouldn't come back, worried that they would disengage with services if they brought up the topic. So these are all direct quotes from healthcare professional interviews that we did about this. It's a balancing act. You know, we try and mention it, but then pull back if they get upset. They worry that the patient, they're going to shut down. You know, so a lot of anxiety around talking about the topic. Very worried about damaging the child's self-esteem as well, and then a worry about the lack of training in doing that. And I think one of the reasons why it came out in our third theme is that that parents really felt they were blamed by healthcare professionals. If they came in, the weighing part of the annual visit was incredibly stressful for parents in case their child had put on weight. And they would see then that their parental kind of abilities would be questioned. And that they were very much responsible. And although they felt responsible for it, they also looked to the healthcare professional for solutions, and often that wasn't forthcoming. So parents really talked about wanting acknowledgement from the healthcare professionals about how difficult it is. So not only is it difficult to manage children's weight anyway, especially in our environment these days where, you know, there's a lot of computer games and junk food around. I mean, it's in what they call an obesogenic environment. But they also wanted the healthcare professionals to acknowledge how hard it is in a child with a disability to try and tackle this on top of everything else. And they wanted the healthcare provider to empathise with the struggles they were experiencing. And so one of the mums said, I suppose it's fine to bring it up, but try not to make you feel uncomfortable, like, not to blame, or make you feel guilty that maybe you weren't looking after your child like you should have been. So, a huge amount of kind of guilt and blame being felt by the parents. So really trying to avoid this sort of situation. And then something which I think, again, ties back to the last talk is this idea of kind of the number on the scale versus how the child or young person feels. And so we saw parents sort of saying, I'm more concerned about how she feels about herself than working on an actual sort of number on the scale. And I think sort of, most of weight management now generally is moving away from that. But there was, again, a sort of tension between the medical approach and, your number's gone up, to how do you feel about it? Is it affecting you? And sort of working within that paradigm. I mean, there are not exceptions, but when, children's weight is at a dangerously high level where they're risking severe health problems, I think that's slightly different. But certainly for sort of lower weights, then it's a little more sort of, we need a bit more of a holistic approach. And not only that, often most of our kids come into the spina bifida clinic once a year, and they have a huge line, things they want to talk about, and they see the urologist, the pediatrician, the occupational therapist, they're there all day. And so the topic of weight often is not addressed because many, many other things need to be. And so we saw our healthcare providers also having different priorities about what to talk about as well. Sometimes they had to talk about other things. So I'm going to skip over that. So what we wanted to try and, once we wrote our paper, it came out, but we wanted to what can we do with this information? So we created a series of simulations. Do you use simulations for training here? Kind of basically videos, and they've become quite popular in sort of now medical nursing training. Having videos to watch and then actually putting yourself in that place afterwards and sort of play through the scenario. So we developed 4 simulations using a lot of the words we heard from our interview studies. We've developed them as sort of training tools, and they're specific to spina bifida at the moment. But I mean, they're also applicable for many others, and I think applicable for how to talk about other difficult things like sexuality, like continence and things like that. So I have one, it's just a couple of minutes long, that I was going to play for you. We developed these with the University of Toronto. They have this standardized patient program there, and they are all actors that you can then hire who do like medical examinations and in nursing training, and you can hire them to do and they're very good in, they make it the same every single time. They've had training in that to make it a fair exam process. So we hired them to do these. So these are all actors you're seeing. And of course, this did work when we tested. Oh, here we go.
I'm sorry I'm a little bit late, Andrew.
That's all right.
It's a bit crazy around here as usual.
Yeah, it's been a long day.
Right. So thanks for coming in. And I have Salma's chart here. I wanted to show you some, they're kind of startling things for us.
All right, Selma's down in orthotics. Should we wait for her?
No, we don't need to. It's all right. I wanted to explain it to you so you can get a handle on what's going on.
Okay.
So if you look at her growth trajectory here, you can see that she's jumped to standard deviation, which is not a good thing.
What does that mean? I don't.
It's a standard deviation. She's jumped off of her curve here. You see.
Okay. I guess. Okay.
Right. So she's gained some weight. She was 35 kilograms last year.
Yes.
At this time, and she's jumped to 46.1.
That's a large gain, is it?
Yeah, it's 11 kilos. So she is it's put her in the 95th percentile for girls her age.
Okay.
And that's not something that you or your wife, I'm sure, want to have happen.
No.
But nevertheless, it has.
What's this? Is it the BMI?
Right. So her BMI, as you can see here, is at 24.1, and so.
I'm not quite sure what that means.
So you seem confused.
I am. Yeah.
So, well, BMI is her weight.
Yes.
Which is presently at 46.1, and we divide that by her height, and then we multiply that by 10,000, and that's how we arrive at her BMI.
Okay. Okay.
Right. So we need to make some changes. Her energy balance it has got to be more regulated. Her energy expenditure as it relates to the energy balance. So she needs to begin to eat more energy-friendly foods.
Okay.
I can put it in terms you will understand.
Yeah, I mean, we try with this stuff. We do everything we can.
Well, I unfortunately, everything you can has led to a jump in the standard deviation. Okay. So we really. I'm not sure what you can do, but you need to do it. I can give you some pamphlets. I can give you some information.
Yeah. I mean, I'll take all this back, and yeah, my wife and I can take a look at it.
Well, good. Well, thanks for coming in.
Thank you. Thank you.
So the perfect consultation. And it is funny, but it's actually sad that we've taken what they said from our interviews of how people have worked with them. And of course, it's slightly exaggerated for training, but I mean, we've all been guilty of doing some of that occasionally. You know, well, here it's on the graph. Like, what? It's up here. I mean, growth charts can be quite useful communication tool. Of course, you know, it can sometimes give parents a visual way of understanding. But anyway, we have 4 of them. So that was on information giving, and just the fact they didn't wait for the child, and they didn't, you know, so many different things. We have 3 others on different aspects as well, talking about, I can't remember what the 3 of them are, but they are all centered on sort of client family-centered care. So we have these different examples. And then with the training, people would look at them, and then they would go into that situation with a standardized patient and try it out for themselves and see, okay, what would be a better way to do it, and so on. So it's meant to be kind of a safe place for people to try out different things, you know, try out different words, try out different ways of approaching it without having to worry about the patient in that situation. So we are getting a grant, hopefully, to evaluate them to show whether they are successful in changing people's practice or at least enhancing it. The Spina Bifida and Hydrocephalus Association of Canada funded that, as well as actually the previous work I've been talking about. And we'd really like to expand that to a lot of it is around, it could be generic, you know, it doesn't have to be Spina Bifida. It just happened to be who funded us. So that's what we're doing around talking about it. We also actually, we've just completed a scoping review of how to talk about weight generally with all children. I've got a very excited face in front of me. We're just going to submit it for publication soon, hopefully. And that was all children, and we were interested in, but how does a rehabilitation context change that? Because if you've got a child with a long-term condition, you probably want to approach or need to approach it in a slightly different way than a typically developing youth who's gone in for his pediatrician check or whatever. So we're just publishing that. There was nothing on rehabilitation, absolutely nothing. So we still don't know. So I wish I had all the answers for you. You can all leave now if you want. Don't have the answers, but so that was an interesting thing about looking at what actual evidence is there around how we should talk about this. Anyone who's interested, I'm happy to chat afterwards about it. But I was going to talk quickly about, we've done measurement, we've done communication, and then what do we do about it? So I just wanted to run through some research. We did a scoping review of obesity prevention for children with physical disabilities, and we ended up only finding 34 studies that actually met our criteria. We wanted to have obesity prevention specifically, but actually we didn't find anything. So we had to say any intervention that looked at physical activity or nutrition more broadly. So we had 34 studies. Vast majority was only focused on one health behavior, so either diet or physical activity. They didn't take a very broad approach. And only a quarter of them actually looked at whether they had any effect down the line. So, you know, you can get a kid in to go on to a stationary bicycle every week for 12 weeks and they will lose weight and get more fit. But then when that stops, then what happens? So very few people actually measured that. And I mean, that's the holy grail for us, is how can we engage kids in these behaviors long term? And we actually found a systematic review as we were looking, and we said, oh, this is great. So we looked from their studies. So I think they had 56 studies in their review. We found 55 of them. And the vast majority actually explicitly excluded children with a disability from the studies they included. So we don't even have the evidence. Kids aren't even being involved in the research that's happening. And so it makes it very hard to make evidence-informed choices and practice if we don't have this evidence available. So we tried to do something about that. And the interventions we came across were mostly physical activity. And sports. Those were the main things: fitness, activity, and sports. A little bit around nutritional status and some around healthy weight, but most of them were focused on that physical piece. And then what we found was we looked at all the papers that reported having a positive outcome. And so we then tried to characterize, well, what is it about these studies that we think might have worked? So around the physical activity studies, those that reported a positive outcome talked about having self-direction of the child. So again, giving the child control, giving them about picking their goals and picking what they wanted to do. Using motivational strategies. Within the fitness, we looked at strength training and incremental increases in workload. So something that you would probably do anyway. And then in the sports participation, it was about being tailored to that person's abilities. So again, you can just rethink about what we talked about self-promotion, health promotion, self-management, wellness, that these key aspects were all associated with positive outcomes. And we actually did this after the wellness thing. So it's we can see the theme going through. And then the target is the child of the intervention. So some studies have just focused on parents, like obesity prevention, and not involved the child at all. They've shown some success, but I think most of the literature is saying about involving the child in it. And so our sort of take-home message from that is that we don't have a robust evidence base for interventions, that can put a lot of people off even talking about it, because they think, well, if I say it's a problem but I don't have anything to offer, then, have I made things worse? So we don't have a very robust evidence base, but most of it hasn't looked at health promotion. It's looked at just fitness or just healthy lifestyles. But we do have some preliminary evidence that we can consider that need more research. So when we're thinking about strategy, we think there's no current evidence to guide the treatment and management and communication of children with disabilities. But I think we have identified some practices that do enable participation and engagement and really promote that kind of health and well-being in children with disabilities. And I think these for me are the promising approaches. So no surprise, be strengths-based. So what can the child do? What are their abilities? What do they love doing, want to do? And then tailor it for that child's and family's abilities. So if it's unrealistic that they are going to find an accessible gym and go every day, then, that's not the best way forward. So work with the family. And that's some of the simulations we did as well, about examples of how you can do that negotiating process. title is wrong, but anyway. So being inclusive, we have to advocate for resources that involve our kids with disabilities into some mainstream programs where appropriate. Again, I mean, I went to Canada thinking inclusion, integration, involve people with disabilities in everyday activities as much as possible. We're typically developing kids. And over the years, I have seen, and we talked about this last night, I have seen sort of the benefits of having disability-only communities and groups, and it can provide a safe place for kids to go and try things out. But I still think we need, at the same time, advocate for mainstream programs to have the ability or to support them in including kids where they want, that's what they want to do. Because sometimes they want to go and work with their peers and work out and, you know, be in groups. And then obviously that's sustainable. We have to look at what helps long-term behavior change. Short-term behavior change really is, you know, is as far as we've got these days in the research, but we need to figure out how can we make that sustainable. You know, from our research, we talked about acknowledging challenges. So, you know, acknowledge the parents, this is hard. This is hard, you know, not rather than, oh, well, you should be able to do this easily. And that can make parents feel very alone and responsible and guilty. And then a concept around obesity that I like is called best weight versus ideal weight. And this is from Yoni Friedhoff and Arya Sharma, who are sort of two of Canada's leading obesity researchers. And Arya Sharma actually formed the Canadian Obesity Network. And they talk about a patient's best weight is whatever weight they achieve while living the healthiest lifestyle they can truly enjoy. And I mean, I think about myself, my quality of life would go down if I could never eat chocolate again. It's just not going to happen. So it's about working, you know, they talk about sort of these crash diets. Anyone who's been on a diet where they've dropped a lot of weight, you know, your body is programmed for it to regain, unfortunately. And so they're talking about kind of not encouraging behaviors that can't be sustained and that could lead to greater weight change, greater weight increase later on. So what's feasible, what's acceptable to the families. This is just an advert. So 2 years ago, I ran a 2-day workshop at Holland Bloorview and brought in people to talk about what should we be doing in the obesity research in physical disabilities then. And we had 2 days of speakers, and our paper actually was published called A Call to Action, and Marie has a copy. But from that, I formed the Disability and Obesity in Canadian Children Network. And that is meant to be a way of connecting researchers who are doing similar research, but also not just researchers, but clinicians, families, anyone who has an interest in this area can join our network. It's currently not hugely active, but it's certainly a good way for people to know who else is working in the field, because we found, you know, there's a researcher here, and then there might be another researcher at the other end of the country, and so it's a way of bringing it together. But we encourage our international colleagues and collaborators to also join. We have people from the United States and from the UK who have joined it. So if you have an interest in this and have an interest in kind of learning what other research is going on, then please do come and find us online. So all this work has been achieved with many other people, not just me. So I just wanted to acknowledge the research assistants and graduate students and colleagues who have contributed to this. Represented here, we have nurses, physicians, psychologists, dietitians, as well as many students. So it's truly been a collaborative process, which I think has led to our success in it, to try and take in everyone's perspectives. So I want to acknowledge that and say thank you for, I made back the 10 minutes that I went over last time. Just a thank you again for inviting me, and happy to take questions or comments or thoughts from people.
Okay, thank you, Amy. Are there any questions or comments? Okay.
I have a couple of comments. First one is
So I'll repeat that as two comments. The first one is that many healthcare professionals are afraid to bring it up, which I agree, and we certainly found evidence for when we've, not only in our interview studies, but me just talking in the coffee line to people. So I would absolutely agree. And I think your second comment was that, but we need to, because it's a health issue, not a moral issue. But yes, often it does become a moral issue, even if that's not said out loud, because of all of us have assumptions and things that we've developed over the years. So we have to be mindful. I would just say we need to be mindful of doing it in a very non-judgmental way, which was your point. And the literature we've looked at for our new scoping review has certainly reinforced that approach. Yeah.
There is a very interesting paper about the barriers that school nurses yes, you know, and it's very interesting to take the sort of test yourself.
Yes.
You are afraid you have so many complications from before, you don't know the culture, you are perhaps too thin or too fat yourself.
Mm-hmm.
There's so many things which really makes you aware of why it's embarrassing to talk about. But we just submitted a paper, clinical nursing, and it's about focus groups, about school nurses talking about, not wanting to raise the subject, which is very interesting.
I would love to read that paper. So just to repeat it for the webcast. Yes. Okay.
About the well-being in Norwegian, it's translated into trivsel,
Okay.
which is enjoyment. Sort of.
Okay. I won't try and say it.
Often you think that quality of life is sort of high profile and people don't really, but just to use Norwegian virtues is the same as well-being.
Okay. There could be a collaborative paper there. So just to repeat it, just raise the topic of school nurses, and that's something we've not looked at, but I think would be a very interesting area, and some of the barriers that school nurses find to discussing it. And a colleague of mine in the UK has done some interesting research about the weight status of healthcare professionals and dietitians, and how much kind of clients or patients take their advice depending on whether they have overweight or obesity and so on. So I think there's a lot of very interesting work there around that area of nursing and sort of community healthcare professionals. And then your paper sounds very interesting around the barriers to discussing weight. So fingers crossed it gets published and I can get a copy, because I think that we really need more research in this area. I think so. Thank you. Yes. Yep.
Very few write about diet. It's a big taboo. And because of that, we give them pretty bad advice because you have to exercise a lot in order to lose weight.
Mm-hmm.
Minimize your weight. It would be so much better if they also got pretty simple diet.
So yes, many of the papers are around physical activity rather than diet, and certainly we need the combination. And I mean, the evidence has shown in typically developing kids that adults, that physical activity doesn't contribute to weight loss. It contributes to weight loss maintenance, but it's the diet piece that's a real significant part in weight loss. So yes, we absolutely need to be integrating that into the advice that we give, and it's a considerable issue for dietitians. We have very little dietitian cover, especially for clinics. I mean, we have 2 and they do the entire hospital. So it's definitely something that we need to be integrating more, and also eating for health as well, not just weight loss. So eating for wellness as well. Yeah, thank you. Mm. Mm-hmm.
and how to stay healthy. I think we need cooperation between different parts.
Yes. Yes. So talking about sort of physical activity or physical education teachers and leaders who lead physical activity groups. There's definitely a real need, I think, for people to develop that physical literacy and to how to move their bodies. But they often feel very uninformed about how to do that safely. And we routinely see the kid with a disability being the referee or the scorekeeper, you know, who's sat on the side. They're in the class, but they're not. They're sitting on the side, not involved at all. And we definitely need some more work in schools to help them feel more confident of involving young people with disabilities into the regular school classes and physical activity classes. So a colleague of mine at work is doing something in Virginia Wright. She's a physiotherapist and she's looking at integrated kind of groups, but she does I can't remember, she's got a fun name for it, but they spend 8 weeks learning how to catch a ball, how to walk on a line, those things that you need to be able to join in groups, sporting activity groups. So, which I think is a really interesting approach. Those are what they call fundamental skills, because they're not learning them in schools. So that's definitely the school. We'll do an intervention. It will be school nurses and physical education teachers. That's our next study. Yes. Mm-hmm.
Thank you for two very interesting presentations. It's so difficult to choose which question to ask because it is buzzing with new thoughts. And so you might already have said something about it, but I was just wondering, could you say something about to what degree did the kids find that the obesity were a big problem, and how to include kids' suggestions in what to do about it, because I think sometimes it's easy for us professionals to identify a problem and have lots of suggestions that we think are great.
Yes.
It doesn't fit in, and they just say absolutely nothing is going to happen.
Yes. So. Okay, so first question, just for the webcast, is about how much children contributed to the discussion about things they wanted to do. Is that right? Sort of, or strategies to deal with weight loss? Oh, how are they included? So, So we didn't interview just children who had overweight and obesity. We tried to, because it's very hard in recruitment. We can't sort of go up to children and say, oh, we're doing a study on overweight and obesity. Will you come and be part of it? We're aware of the value judgment, so we don't want to reinforce that. So we always have a mix of children involved. But so many of the young people knew they had a weight issue. They more had like sports or inclusion goals. So it was more important for them to keep up with friends or to take part in a soccer tournament or whatever it was than the actual weight. So I think that's why we have to be mindful of the different priorities that are going on within that sort of the triad, as I was saying, the three things that everyone might come to the table with different priorities and different motivations. So as healthcare professionals, we need to figure out what is the motivation for them. And often it's the inclusion, friendship, peers piece that is the motivator, and to become more included. Does that answer your question? Some, maybe.
Yeah, and especially when I was working with Bifida, working around the weight issue, actually both with regard to adults and kids, is also the way we understand. Because I remember we had a person in here, obviously we agreed on that weight was an issue. So we were trying to We're trying to arrange meals differently. Until I thought, okay, this sounds really good. It sounds really healthy. It sounds like you're eating all the right things. I'm just wondering, what do you eat when you're going to have a good time, sort of, in front of the television and blah, blah, blah. And then the whole story came out. And she wasn't thinking, she was eating healthy.
Yes.
The other thing was, so the 3-4 meals were perfect, but in between was not regarded as, I don't think she was trying to teach, kind of.
Well, we've all done that. Has anyone here ever tried to keep a food diary? Yeah, mine is patchy, shall we say, of things that you forget or accidentally forget on purpose, and so I think that's a key issue. But again, sort of, what would you? So saying you can't have any chips or any cookies or anything in front of the TV is unrealistic. So working with them, saying, well, what would be acceptable? Would you have maybe some chips and some carrots, or I don't know, but sort of working, saying what would be this sort of the quality of life, what would you still be content with, but that we can start making kind of some changes into your diet. One point that I did forget to mention, and you just sort of came up, made me think about it, is that which healthcare professional to bring it up is an issue. Because when in some of our research, we've found that the physician leaves it to the nurse to talk about, the nurse thinks the physiotherapist is going to talk about it, the physiotherapist thinks the OT is going to talk, so no one's talking about it, or multiple people are bringing it up. And in our study, one was saying about, she was a physician and she said to a young person, what do you think about your weight? And they burst into tears and said, you're the third person that's told me about this today. So I think the team communication, it didn't really matter who it was. The children and parents said they didn't care whether it was the nurse or the physician, or they didn't care. It was whoever they had the best relationship with. And so within the team, we just need to make sure that someone's bringing it up and not everyone's bringing it up. So I think that's a key point. Again, you just made me think about it, about what children and parents want. It's actually not one option, but often we know the nurse in our clinic does a lot of the dietary stuff, so it might make most sense in our clinic for the nurse to do it, but something that each team need to think about, and then talk about the sort of the quality of life issue as well. Okay. I'm around today and tomorrow, so if anyone has any burning comments or questions, if you contact Marie, and I'm happy we can talk about this more if anyone has any thoughts or comments. Ooh, one last one.
One more. My last one, because I was so thrilled that when another health psychologist was coming, because I'm also a specialist in health psychology, which is a specialty that doesn't exist in Norway yet.
Doesn't exist in Canada either.
It's very strange.
We're unique.
So my just last comment was also this thing with obesity, like it is with other issues, which is also relevant when you have a disability. It can also be a cover-up for people having difficult time, and so sometimes it might be not so much about that they don't know what to eat, but they are having a troublesome life where they maybe, especially when they're youth, they get lonely, they drop out socially, and so they don't really know what to do with themselves. So,
yeah, the psychosocial issue is huge in all obesity treatment. I think, the best practice in obesity treatment is to have a psychologist involved, and I think you're right, especially in disability, they have a hard life. Many have very challenging circumstances, and food may be used with that. So a good comment to end on. Okay, thank you everyone for your attention, and again, thank you for inviting me.
I'll say this in Norwegian, Amy.
Okay.
Vi takker Amy for at hun ville komme, og jeg er helt sikker på at vi kommer til å følge flere av hennes publikasjoner fremover. Og så er det jo mulig å ta kontakt med henne hvis man har noen temaer eller noen ønsker. Som dere har oppdaget, hun er lett å snakke med og ta kontakt med. Så takk igjen for at dere møtte opp da. Ha det bra. Thank you. I enjoyed it. Keep it